Good morning, everybody. I am Dr. Balasubramaniam Tyagarajan. Today, I am going to discuss adenoid. Adenoid is actually a component of the inner valvulary, and it has a very important role to play in the immune mechanism of the body. So, now a little bit into the history of adenoid. It was Mayer who actually first coined the term adenoid, and he used this term to describe the nasopharyngeal vegetations. As he saw in his routine dissection, adenoid appeared to be a small vegetations, a small crop of tissue arising in the nasopharynx, and he called it, and in fact he described it precisely as nasopharyngeal vegetations way back in 1870, and he coined the term adenoid to describe this vegetation. Then Santorini described this tissue or vegetation as lymph tissue, and he identified histologically the tissue to be of lymphoid in origin, and he coined the term Lushka's tonsil to indicate the aggregate of lymphoid tissue in the nasopharynx. And adenoid is actually associated with upper airway obstruction, and it can act as a focus of sepsis in the medullary cavity as far as inside the paranasal sinuses and nose, and it can also be a cause for persistence of otitis media with effusion or a serous otitis media in early childhood. It should always be remembered that this is actually the first microbial contact zone. So when the child starts to breathe on its own, the atmospheric air along with the suspended virus particles as well as bacterial agents come into contact with this tissue, and this tissue is really helpful as a immune mechanism zone, and it processes the body's immune system to recognize the bacteria as well as the virus. Now let us dwell a little bit into the developmental anatomy. Adenoid actually starts to form at the third month of intrauterine life, and it starts actually as a glandular primordia in the posterior nasopharynx, and slowly it becomes colonized by infiltrating lymphocytes. And this tissue is supplied by the facial artery as well as the maxillary artery, which are branches as well as branches of the thyrocervical trunk. I repeat again, adenoid is actually supplied by facial artery, maxillary artery, as well as the thyrocervical trunk. And nerve supply to the adenoid is from the sensory branches of glossopharyngeal and vagus nerve. That is the reason why adenoid inflammation as well as pain following adenoidectomy is referred to ear, because ear also receives sensory supply from glossopharyngeal as well as vagus nerve. So this is actually a referred autalgia, can be caused due to adenoid pathology or post-adenoidectomy. Children, referred autolgia is a common occurrence due to this shared nerve supply. Adenoid is actually relatively large in relation to the volume of the nasopharynx in the 7-year-old child. So, when the child is 7 year old, the adenoid tissue, volume of the adenoid tissue is proportionately higher when compared to the volume of the nasopharynx. And a little bit into the, let us dwell a little bit into the venous drainage. It drains into the venous drainage of the adenoid, actually drains into the internal jugular and facial veins, and lymphatic drainage occurs into the retropharyngeal lymph node, which happens to be the first achillon node, and later this retropharyngeal node drains into upper deep cervical nodes. And on routine MRI, it has been identified that adenoid tissue becomes visible in a child of 4 months of age, and in fact it is visible in 100% of the children at the age of 4 months. Let us dwell a little bit into the immunological function of adenoid. Adenoid has been postulated or known to produce B cells, and it also gives rise to IgG, IgA, as well as plasma cells. So this indicates that this tissue has a huge role to play in the normal immune mechanism of the children. And adenoidectomy, without saying that this in the early childhood, if it is performed, it can have undesirable consequences uh, as far as the immune mechanism of the child's body is concerned. There could be a depression of the immunity if adenoidectomy is present in early childhood, and it appears to be playing a vital role in the development of immunological memory. So what exactly you mean by immunological memory? So when the adenoid tissue comes into contact with the pathogen, it has a core system of cells, and these cells constitute a memory, immunological memory. So if the body gets exposed to the same organism, the immune mechanism takes shorter duration to stimulate the immune cells and to counter these organisms and to inactivate these organisms. So, this immunological memory has a huge role to play in the defense mechanism of the body. And early adenoidectomy, I wish to stress again, has a negative effect on the development of serum IgG antibodies as well as antibodies that play a role in reducing the effects of pneumococcal infection. So, studies have really revealed that children with early adenoid who have undergone adenoid surgery early in their age have reduced immunity to pneumococcus. So, that is very important to understand that immunity to pneumococcus takes a hit when children undergo adenoidectomy at a very early age. So, in children aged 4 to 10, adenoidectomy has relatively less or no effect on the immune mechanism of the body. So, in other words, children under the age of 4, if they undergo adenoidectomy, it has a deleterious effect on the immune mechanism of the body. So, in children aged 4 to 10, adenoidectomy has not known to cause any untoward immune deficiency. And let us dwell a little bit into the pathological effects of adenoid enlargement. So, adenoid enlargement, what it happens is that adenoid tissue, I've already told you, is a component of the inner Waldes ring. It forms a chain. The inner Waldes ring, it is a component of the inner Waldes ring chain. So, this is in contact with the tubal tonsil submucosally. So, submucosal lymphatics connect adenoid tissue with the tubal tonsil also. So, when the tubal tonsils enlarge due to adenoid hypertrophy or adenoid inflammation, it causes a block in the eustachian drainage, and this causes secretory otitis media in affected children. And presence of enlarged adenoid tissue can be a focus of persistent infection of the nose and paranasal sinuses. And persistent adenoid inflammation can cause inflammation of the tubal tonsil, thereby allowing the infected pathogen to spread into the middle cavity, causing acute otitis media. And children with adenoid hypertrophy are prone to mouth breathing, and so they are known to snore. So snoring is literally unknown in children. If the child snores, it goes without saying that adenoid tissue has hypertrophy and it is compromising with the nasal airway. So snoring in children should always be viewed with caution because it indirectly indicates adenoid hypertrophy. And then it has an effect on the olfaction also. So olfaction not only takes place from the nasal airway, it also has a role. The oropharynx also has a role in transmission of odoriferous molecules to the olfactory bulb. So this is actually indicated by the blue arrow. So when the oropharyngeal airway alone is active, when the nasopharyngeal airway is blocked due to enlarged adenoid tissue, these children have only one route for the odoriferous molecules to reach the olfactory cleft. So there will be a diminution of sensation of olfaction. And unilateral enlargement of tonsil along with enlargement of adenoid should always be viewed with caution because this could be lymphoma. So, neoplasm involving the adenoid tissue should not be overlooked when a child is presenting with adenoid hypertrophy. Now, let us discuss a little bit on one of the complications of enlarged adenoid tissue pertaining to the ear. So, enlarged adenoid tissue can cause obstruction of the nasopharyngeal uh, tube, eustachian tube or nasopharyngeal tube. So, what happens is this is actually the size of the adenoid can cause blockage of the eustachian tube by subsequent enlargement of the tubal tonsil because adenoid is connected to the tubal tonsil by submucosal lymphatics and excessive adenoid tissue can cause physical compression as well as adenoid inflammation can cause inflammation of the Luschka's tonsil or the tubal tonsil of Gerlach. So tubal tonsil of Gerlach can be inflamed along with the adenoid causing blocking of the eustachian tube drainage channel. So, adenoidectomy per se has a beneficial effect in the management of otitis media with effusion. And otitis media with effusion has been attributed to the formation of bacterial biofilm within the midline cavity due to the persistence of the midline secretions. And recurrent or chronic inflammation of adenoid has always been associated with the increased load of Haemophilus influenza. I again wish to repeat that recurrent, acute, or recurrent chronic infection pertaining to the adenoid is always associated with Haemophilus influenza. Then the next important autological complication of adenoid hypertrophy happens to be recurrent otitis media. So, adenoidectomy has been found to be really effective in reducing the number of episodes of acute otitis media in children. And I wish to stress again adenoidectomy should not be recommended as a management of AFOM and low dose prophylactic antibiotics can be used as a treatment modality for children suffering from recurrent acute otitis media and selective IgA deficiency, which is actually an inherited immunological problem, should always be looked out in children with recurrent acute otitis media. That should not be forgotten or overlooked rather. And another complication of adenoid hypertrophy happens to be obstruction to the nasal as well as the nasopharyngeal airway. Childhood sleep apnea has been known to improve following adenotonsillectomy and airway obstruction caused by adenoid hyperplasia can reduce partial pressure of oxygen and can also cause an increase in the partial pressure of carbon dioxide in the blood. And studies have revealed that these values have a tendency to return following adenoidectomy. And radiological assessment of the size of the adenoid has an important relevance uh, and correlation pertaining to the severity of the obstructive sleep apnea syndrome. Rhinosinusitis. Actually, this is again one of the complications of adenoid hypertrophy. Studies actually reveal that children with recurrent sinusitis showed dramatic improvement following adenoidectomy, and their episodes of rhinosinusitis really decreased following adenoidectomy. And studies have revealed that in childhood, adenoid has been implicated as a reservoir for pathogenic bacteria, and that should always be borne in mind. When you do adenoidectomy, you are removing the reservoir of infection. Then, what I told you, children with adenoid hypertrophy has a diminished sensation of olfaction. So, retronasal smell and taste can also be affected by adenoid hypertrophy. And adenoid hyperplasia can reduce olfactory sensation, and these children can have hyposmia, anosmia, or taste disturbances. And these symptoms improved when the child underwent adenoidectomy. And it should always be borne in mind that loss of smell is actually does not caused by the physical obstruction, but it has been attributed to changes in the olfactory epithelium. I wish to stress again, loss of smell or reduction in the smell, hyposmia, is not caused by physical obstruction of the airway alone. It has been attributed to changes that has taken place in the olfactory epithelium due to adenoid hyperplasia. And then I've already told you I made a passing mention of neoplasm involving the adenoid tissue. So unilateral enlargement of tonsil combined with adenoid hyperplasia should always be viewed with caution, and it should be construed as an indication for biopsy, excision biopsy rather. So adenoid hypertrophy in the absence of infection should always raise the suspicion of lymphoma. And lymphoma of adenoid could actually be a part of post transplant lymphoproliferative disorders. So, in a patient who has undergone renal transplant or a liver transplant, these patients can have enlarged adenoid tissue, and lymphoma should always be ruled out in these transplants. And let us grade the size of the adenoid clinically so that we will have a scientific way of documenting the enlargement of the adenoid tissue. And acoustic rhinomanometry, which is a tool wherein the instrument or equipment connected to the nasal cavity and oral cavity measures the sound produced by the air entering into the nose or mouth, and that provides a useful estimate. The turbulence of the air coming in and out of the nose and oral cavity provides a useful tool to estimate the adenoid volume. And the gold standard of adenoid volume, tissue volume, happens to be the MRI. It provides the most accurate volumetric estimation of adenoid tissue. So clinically, we grade the adenoid hyperplasia or hypertrophy into four grades. Grade 1 is actually the adenoid tissue which goes to the extent of filling up one third of the vertical portion of the choana. I repeat again, grade 1 is where the adenoid tissue manages to fill about one third of the vertical portion of the choana. In grade 2, adenoid tissue manages to fill one third to two thirds of the choana. In grade 2, adenoid tissue manages to fill one third to two thirds of the choana. In grade 3, the adenoid tissue fills around two thirds to nearly complete portion of the choana. Grade 4 is actually total obstruction of the postnasal space or choana. And let us go into the management. Studies actually suggest that topical nasal steroids spray, as administered as spray, can cause a reduction in the size of the adenoid. Of course, in addition to the suggested improvements in the middle ear fluid volume. So, in children with secretory arteritis media, in addition to the systemic antibiotics, can also be administered a course of topical nasal steroid spray. Actually, topical steroid spray has the advantage of local action, plus it is sufficient if very small dosages uh, can be administered, say around 100 to 200 micrograms, not milligram, micrograms. So that really shrinks the adenoid tissue. And topical steroid spray also revealed that audiometric thresholds in these children showed dramatic improvement. The incidence of rhinorrhea and cough also showed significant improvement. Then surgery. It is always better to combine removal of adenoid tissue along with tonsils, because if you remove adenoid tissue and leave the tonsil undisturbed, there will be a compensatory hypertrophy of the tonsil tissue. Vice versa, if you remove the tonsil tissue and leave the adenoid in situ, it can undergo compensatory hypertrophy. So it should always be combined. In my opinion, personally, adenoidectomy should always be combined with tonsillectomy. And in addition, grommet insertion also can be combined. So in children with significant medullary fluid accumulation or secretory otitis media, adenoidectomy followed by grommet insertion will go a long way in ameliorating the problems of the child. Coablation adenoidectomy currently is being commonly performed because the basic advantage is it is performed under direct vision, and the complete removal of adenoid is possible if coablator is used. And the conventional adenoidectomy is actually a blind procedure which is being performed, which was initially performed using adenoid current. Currently, we have ways of visualizing the adenoid tissue using a nasal endoscope. So you can combine the visibility of the nasal endoscope along with the conventional adenoid curate adenoidectomy. So this gives you the advantage of performing adenoidectomy under vision. So in my latest slide, I will show you exact surgical procedure, a video clipping of the surgical procedure where we have managed to combine the direct visualization of the adenoid tissue along with the use of conventional adenoid current. I will also show you surgery adenoidectomy which was performed using a coablator under direct vision. So adenoid surgery has its own complication. It can cause bleeding, it can cause residual infection. While the surgery is being performed and the mouth is being kept open using a mouth gag, it can lead to dental trauma, and then adenoid inflammation can be one of the causes of Grisel syndrome. Atlanta occipital dislocation can occur when mouth gag is applied in these children. So we should always be careful to avoid dislocating the Atlanta occipital joint while mouth opening is being performed. And post surgically, since nasopharynx is a hidden area, swabs which have been placed to tamponade the bleeding can be retained following surgery. And then adenoidectomy can cause velopharyngeal dysfunction transiently. So, and then presence of nasopharyngeal blood clot can be cause for concern, and adenoid tissue can show regeneration following surgery, and we use the term adenoid regrowth to indicate it. The next is I am going to show you a adenoidectomy procedure wherein we will be using a nasal endoscope to visualize the adenoid tissue while we are planning to use a conventional curette. So, so we have put the nasal endoscope. We have visualized the nasopharynx using nasal endoscope, and this is actually the adenoid tissue. So you see the curette being inserted through the oropharynx. The curette totally locks the adenoid tissue. It can be seen clearly that curette is locking the adenoid tissue within its walls, and then it is being scooped out. So under vision, if you manage to do adenoidectomy, so you see the entire adenoid tissue is found to be totally removed in toto. You can beautifully see the furrows also inside the on top of the adenoid tissue. So now I'm going to show you a video wherein we'll be seeing the use of coablation in adenoidectomy. I think you should be seeing the video soon. So the adenoid tissue is visualized using you visualize the adenoid tissue using endoscope, and then the gallbladder is introduced through the oropharynx, and you have a wand, gallbladder wand, specifically designed to reach the adenoid tissue. It will be a curved wand. Now you see the gallbladder in action, gallbladder wand in action. It is slowly removing the adenoid tissue. It is ablating. You see, the moment it gets close to the adenoid tissue, the tissue just melts in front of the eye. This is one beautiful way of removing adenoid tissue. I think you should be able to appreciate the gallbladder wand ablating the adenoid tissue. Since this procedure is done under direct vision, uh, the completeness of removal of the tissue is ensured. Thank you.